Welcome to Health Systems CIO's interview with Northeast Georgia Health Systems CIO Chris Paravate, Medical Director for Perioperative Services Dr. Ron Lewis, and Robotic Surgeon Dr. Chad Copper. I'm Anthony Guerra, founder and editor-in-chief. Gentlemen, thanks for joining me.
Thank you for having us.
All right, great. So the reason we have come together here today is because, Chris, I saw you put up a post where you were sort of echoing Dr. Copper's post about robotic surgery. So excited to talk a little bit about that and how clinicians and IT can work together on these type of projects. But first, Chris, if you want to just start out by telling us a little bit about your organization and your role.
Yeah, so I'm Chris Paravate. I'm the health system CIO here in Northeast Georgia Health System. We have 5 hospitals, a number of ambulatory locations, probably well over 100. And then we partner very closely with a lot of the physician groups, including Dr. Copper's group, the Longstreet Clinic.
All right, excellent. Very good. And gentlemen, I think your titles are sufficient to describe what you do. So I don't think we need to go into that too much. So the post, let me read the post quickly here. Chris, you commented we do a lot of robotic surgery, and that was echoing on Dr. Copper's post, which said, so proud of our robotic team at Northeast Georgia Medical Center, 25,000 patients helped and healed with Da Vinci robotic surgery. Very blessed to be part of this team. So that caught my eye. Obviously, you've got a clinician, a surgeon putting something up with a big technology angle, and the CIO saying, hey, this is working out really well. So very cool stuff. Let's talk about, Chris, if you want to jump in or pass this off. I'm really interested in the genesis of these type of things. And what I mean by that is clinicians, surgeons are, I'm sure, reading medical journals, staying up on the latest technology. Technology is more and more permeating the actual practice of clinical care, not just the tracking of clinical care, as in the EMR. It's now actually in, I just did an interview and it's on our site about surgeons using Apple Vision Pro, cutting edge. So we're really seeing technology get deeper and deeper into the actual practice of medicine. So I'm interested in how this kind of request even surfaces. How does this come to the surface? When and how is IT brought into the process and the collaboration there? I want to bring stories of that collaboration to light. So Chris, wherever you want to jump in.
Yeah, so Dr. Lewis, maybe you could start a little bit about the genesis of the robotic program, and then we could pass it off to Dr.
Yeah, so we started our robotic program all the way back in 2008 with an anonymous donation of a robot. The interesting part about that fact is it was donated so that we could do cardiac surgery, and we did not do our first cardiac robotic surgery until 2023. So the program has been building that whole time, really starting in 2015. As we begin to add hospitals, we also begin to add robotics. And I think that we just continue to grow sort of exponentially at times with our robotics program. So we now have a total of 9 systems from that one initial system. We're in 2 locations, and with the addition of 3 additional hospitals and an ambulatory surgery center, we're certainly evaluating what our strategy is going to be over the next year or 2 in terms of adding additional robots at those locations. So this is a constant moving target for us. We're not only growing and in a growing area of Georgia, but we are also expanding our footprint in location and in number of robots all at the same time.
All right, so you get a donation in 2008 of a robot, and so for these type of things that surgeons and clinicians are using, you get let's say you get a donation, something like that. Do you then give Chris a call and say, "Hey, Chris, I got a robot. Hey, I think I want to plug it in."
They actually try to get it into the OR without me seeing.
Yeah,
right.
With a lab coat on it.
Yeah. Well, I think that, and you certainly put this out front when we started this, that technology is permeating our environment, and it is no longer optional that we include IT on these types of projects. I mean, it used to be you want to add something to the OR, you just add it to the OR. It didn't require a conversation with 25 other people in order to make that happen. But now, because it connects to something and there's a digital platform or a cloud solution, IT is very, very important to be involved all the way up front. So in 2008, we probably did just roll it into the OR and then called IT, Chris, whoever, and said, hey, it's here. Can you hook this up? But because IT is so involved in everything that we do, we can't do that anymore. So it does require that communication well in advance. You know, fortunately, and thanks to Chris for reaching out to us, we do have a very, very strong partnership with IT that allows us to get these projects in line, and the funds and personnel and teamwork allocated to make sure they come to fruition.
And I do think that Chris and his team have done a good job of educating clinicians in why that's important and what that process is. I think all of us have a really good understanding of, hey, this takes hours, this takes integration, this takes team members, doing, whether it's pulling wire, whether it's just software stuff. But, hey, it needs to go through committee, and it needs to, be allocated hours, and they've done a good job of teaching the medical staff, why that's important.
Yeah, Chris, and cyber is going to come in there too, right? As
Yeah,
one of the
yeah,
reasons you can't just plug stuff in.
Probably some of the exciting benefit though, and I saw Dr. Copper, your post the other day. I mean, you're training some medical staff around the world, on the other side of the world. Could you share a little bit about that?
Yeah, so one of the things that the robot has allowed us to do is to do something called telepresence. So it's the ability to really project a live surgery in a secure way to another clinician somewhere else. So we've really made use of that in a couple ways at our facility. One of the ways that we've been doing for the past few years is what Chris was talking about, is being able to proctor or work with surgeons really around the country and around the world. We have a really good partnership with some surgeons in India, both around Bangalore, as well as a couple other cities in India. And these surgeons, the timing works out great because our day starts at 7 a.m. Well, that's 5 p.m. in Bangalore. So those guys just finish up with their day, and then they're able to log in. And really, it's a real collegial relationship. India, the robotic surgery in India is a few years behind us as far as rolling out, but they have some really talented surgeons there that are very very interested in robotics, and so they're able to watch me. I've got a headset on. We're talking throughout the case. They're asking questions. They're watching not only the case, but live stream videos from the room showing what my staff is doing, how the robot's actually functioning, how it is docked to the patient, all those kind of things. So that kind of real-time interaction is amazing, and it's around the world. So that's been really cool.
Very cool. You mentioned that Chris has done a good job explaining to you the implications of why things need to go through channels and be checked out, and that integration's got to happen and all that. I would imagine that that's got to be done right in terms of the way it's got to be explained, because you don't want IT telling you no. You don't want to be told you can't use this stuff, you can't try this stuff, it's going to take 6 months, right? You don't, because then you won't go to IT. That's why people sometimes try and work around IT, sort of the old model of IT, and then everything went on quietly over on the side. But he did it in a way that made you understand, okay, I get the reasoning why we have to do it, but it's still not okay for things to fall into a black box, right? And we don't know what happened, and we never hear back. So there's a balance there, it sounds like. Can you tell me, again, I'm looking for what you want from IT, what kind of engagement you want and support, knowing that everything can't be done right away and some things can't be done at all. So, Dr. Copper, why don't you go first and then Dr. Lewis?
So the first thing is Chris tricked me into being on a committee. That was probably number one.
More than one.
This was back in like 2018, 17, 19 in there. But it really taught me a lot. It was the committee that and I'm blanking on what even you guys call it, but it's the committee that
It's our IT governance, right?
yeah, your IT governance mean where the hours are divvied up. And we decide, you know, hey, here's the projects I've got, here's the bucket of, you know, person hours that I have to divvy up, and there's not an unlimited supply of that resource. So therefore, and they really the cool thing was they really wanted and still do want clinician input to that, because Chris has said it time and again. He's like, listen, I can't tell whether the ultrasound in cardiology is more important than the X-ray machine in ortho or the robot in the OR. I can't rank those. So you guys rank them, and then I'll tell you how many, how many hours it's going to take me to set all that up. And so that kind of him reaching out and wanting to know the clinical background of it, and letting the clinicians talk to each other and go, hey, listen, here's why mine's more important. Well, here's why mine's more important. And so that committee was really helpful. It still goes on today. And I think that clinical input, and it's not just obviously surgeons or doctors, it's nurses, it's nurse managers, it's, clinical managers, all those kind of people. But it's the clinical people kind of deciding what's important, and then the IT people going, okay, well, here's the hours that we have, or the whatever dollars that we have.
Dr. Lewis?
Yeah, I agree. I think to be successful in Chris's role, I think it has a lot to do with relationships. And so what he has done is to try to form those relationships at all levels of the organization. But and I think the way that he has done that is to add physicians in leadership roles, informaticists, involving people that are actually still clinical, who are doing the work, because nobody can have a conversation with a surgeon like another surgeon. Like, you don't need this on your order set. It's right there. You can add it. If I say that, it comes across in a totally different way than if a random person from IT says it. So I think he's been very smart about putting physicians, PAs, nurse practitioners, nurses in roles where their clinical expertise can be utilized to the fullest extent to help IT do exactly the things that Dr. Copper was talking about. And I think that relationship building is very, very important. And, nothing's perfect from our end. I mean, we do sometimes forget that, oh gosh, we're putting this new robot in. We've got to call IT. And no matter how much we try not to forget, sometimes we do. And when you have a good relationship with somebody, it's easy to have hard conversations with them. If you're trying to build that relationship while you're having a hard conversation, never works. So the fact that we have invested the time to form those relationships before we have those hard conversations, I think is a testament to Chris's leadership.
Well, Chris, let's talk about that leadership a little bit. No, I'm just kidding. I do want to ask you, Chris, because the point was made, the excellent point was made that the users, the clinicians, really need to be ranking. They know what's important to them clinically, what they need, and they're going to help direct you. But also, to be the best CIO you can be, you probably want to learn as much about operations as possible, right? So we're not clinicians. You're not a clinician, right? You didn't, if I remember,
Nope.
you're not a clinician. So what is your advice to others? And do you try and learn about operations as much as possible, just enough to be dangerous? And how do you do that?
Yeah, so long before I was in the CIO role, I was asked to upgrade an old OR system called ORSOS. And the way I did that is I went to the OR leader and I said, I'm your project manager to upgrade this project. And she said, great. And she put me in a bunny suit and a core for the next 2 weeks. And I learned everything about the OR and learned about the pharmacy and learned about how blood products moved and how, all those things worked. And then I could actually advocate for that install. And so at the core of my philosophy in IT and my expectation is that we are going to partner with clinicians in the clinical world. Now, my wife has had surgery in Ron and Chad's OR, so I take it pretty darn personal. I trust our physicians, our anesthesiologists, our clinical team, and they're exceptional. And when they have problems, and Dr. Copper and Dr. Lewis will tell you, I will show up in the OR. And it's not just whether it's a surgery problem or, maybe it's a network problem, but I'm going to take the time to come and explain, just as, I need them to come and explain to me, well, this is important and this is not really important. So it, as I think described, our physician leadership is really important. We got a lot of business decisions to make. We got a lot of clinical decisions to make. It's often amongst really good ideas and lots of priorities. And so the better we communicate and work effectively on that decision making, then we are completely aligned on priorities and we focus on getting the work done. And we can explain that, and we ought to be able to finish each other's sentences about what's a priority. And so that's, early on, I learned that, going through, like I said, it was, I remember the leader and she literally handed me a bunny suit. I didn't even know what that was. But there I was standing in the OR. But I'd learned the value of that really quick.
And I would imagine you try or you require or you expect the people who report to you to do the same, to be out there in the hospital, right?
Yeah, I do. And I value the people, I think about Raleigh, who both of these individuals speak. She will come and stand outside the OR and what's going on? How are you doing? Okay, let me work on that. They know that things are intense and there's lots of pressures. And some of those pressures are not just clinically what's going on in the world. We all have personal lives. So that's what I expect from IT. That's not exceptional support. That's exactly what I expect.
Put this to the doctors. As a clinician, you have to stay up on the latest of your practice, what's going on in your specialty. A lot of that's going to be technology related, these different robots, Apple Vision Pro, whatever it is. So you're hearing about these things, you're learning about these things, you perhaps want to try these things. In order to be a surgeon practicing at the top of your license, so to speak, you need to be doing this, which means you need a relationship with IT, right? Because if practicing at the top of your license is going to include more and more technology, you need a relationship with IT. Does that make sense, Dr. Lewis?
Absolutely.
So
Yeah,
what's go ahead, please.
Yeah, I think that every surgeon wants every toy in their operating room. It is natural. And I think that having that relationship with IT, we have to run trials all the time on different equipment. Do we want this? Do we not? It might require a change in an order set. It might require IT capacity, either for bandwidth or for other reasons. And so we do have to have that relationship, even with new and emerging technology. It's not just stuff that we've made a decision that, hey, we're going to buy this, we're going to implement. It's also the stuff of, hey, I want to run a trial for 6 months. I want to do 30 cases on this. So you do have to have that relationship for sure.
Dr. Copper?
Well, I'd add that, specifically with regard to robotic surgery has been a really disruptive technology to the operating room. It's something that we've never done before. We took a computer and we put it in between a surgeon and a patient. That was groundbreaking. And it enhanced all of the kind of skill that the surgeon brought. So it enhanced our vision and enhanced our dexterity. But on the backside is all the data that we got out of that. And so for the last 10 years, as we've gone through this learning curve, and robotics has become now not some unique thing, but something that we see in pretty much every hospital in America right now. Everybody's been going through this learning curve, and it's been great, and we've seen some big clinical things. But I think the next 10 years is going to be amazing, because that's when all this backside data stuff is really going to come out. And that's when we start talking about things like AI in surgery, which scares the crap out of everybody. But I think for me, it excites me beyond belief. Anything that can make me a better surgeon and can make a surgery safer for my patients, I'm all in. So, when we talk about, the way we teach surgeons, and so now we can get data on like exact hand movements and the force that they're using in those hand movements, and then be able to objectively show surgeons, not just subjectively going, hey, here's how you should do it, but using objective data to show them, hey, here's how your hands move. Here's how a top 10% surgeon's hands move. And here's how we can make you better.
Mm-hmm.
And so that kind of data is something that it's going to really change my world. And it means that my relationship with Chris et al. Has to be as good as it can be, because as we need more and more data, more and more, well, I'm going to need more and more support, and he's going to need to steer us in the way that, hey, listen, this is going to work better if we set it up like this. This is going to, you don't want to do it like that because of X, Y, and Z.
Mm-hmm.
I mean, that kind of partnership is going to be key.
So to have, and let's go with the negative example here, to have a bad for you, Dr. Copper, to have a bad relationship or non-existent or toxic with the CIO of your health system, it's almost like it's almost inconceivable for you to be successful and do the work you want to do with someone who either is not really supporting you, not responsive, lots of no's, everything takes months.
You can't have, in today's world, you cannot have a successful robotics surgery program with a bad relationship with your CIO and that department. I mean, it can't happen. That relationship, and Chris and I have worked together for many years on many different projects. And we worked together on EMR and implementation there. And when we started that, one of the things that he brought out that we've continued through many, many other projects is, IT really has to stand outside of hospital politics, personal feelings, all that stuff, because it can't fail. It's a non-fail type thing. So it has to be outside of all of that. No matter what's happening between organizations, between surgeons, doesn't matter. The IT stuff has to work. So that's, I mean, it's essential for what I do. I couldn't continue in my career if I didn't have that.
Let's talk a little bit about the idea that it can't always be a yes, and it can't always be, but like, for example, it can't be this app that you want because we checked it out and it's got like full of cyber holes and we tried to work with them and this is just not going to work. So we're going to have to go with someone else. We want to get you the tool you're trying to look for, but the one you picked is no good. Right, Chris? Something like that. There could be a discussion like that. So what's the best way to deliver that kind of information? And then I want to hear from the doctors about the best way for them to receive that type of information.
We certainly have seen some of those bumps in the road. And I think part of it is alignment. As we talked about it, we said this is a priority as a system. And then I'm going to get on the phone with that vendor and really understand, what is the problem? What's the nature? What are you willing to do about that? And then I can bring that back to my partners and say, hey, I got some gaps here. And the vendor's willing to commit to this, or they're not willing to commit to this. And this is the why. And I think that's the trust and the partnership and the relationship. You know, our surgical team knows that we want to do it.
Mm-hmm.
You know, it's not a, you know what, we're just kind of busy and we just don't feel like doing it. I mean, we really want to see this. This is really cool stuff. And you know, I mean, we live in this community, and so that IT team is not alone when I say that, you know, we we are patients and we're the IT team. And so I think when we hit big snags like that, fortunately, we've had some really strong uh, vendor partners that have worked with us, have addressed anything that were concerns. And sometimes I got to bend the corners a little bit and I got to measure the risk and say, you know what, this is really important. And that's a measured risk that I think we can manage. So it's not always black and white. Certainly, you know, when you get to the technical team, the more technical it gets, they're going to get to, you know, it's yes or no. And so it's the leadership aspect of us saying, what's the measured risk to the organization and how do we manage that?
Very well said. Dr. Lewis, any thoughts on what you're hearing here?
No, I think it all goes back to relationships. I think that we have become so dependent on IT that uh, it's a partnership. It's almost like we're on their team and they're on our team. It's unusual to get an outright no. It's more of a what's the problem you're trying to solve, and then let us go look for the best solution. You brought us one solution, but there may be more out there. You know, again, I think AI is maybe an overutilized term, and it means a lot of different things to a lot of different people, but it is coming in whatever form you want to talk about. And so I think that there are people that understand that way better than I do. And how to implement that in the operating room, I think is going to require a level of expertise that I just do not possess. So I think it's important that we communicate what the problem is that we're trying to solve, and then what software, hardware do we need to solve that problem. So again, it's unusual to hear just an out no, as long as it fits within the framework of what our mission and vision is of the hospital. It's more about, hey, how can we get the best solution for you for the problem that you're trying to solve?
And some
Chris,
of it has
go
to
ahead.
do with adoption, you know, the level of maturity and where we are in using data and analytics. And every organization is different. One of the things that the three of us are really passionate about is really leveraging three big pieces of technology. The ability to hear in the room, in the OR theater, to be able to sense or track who is in the OR, where are they, what are they doing, and then computer vision, right? To actually be able to see. And while that is continuing to mature at a very rapid rate, you combine the ability to hear and to see with the robotic of touch. And I mean, you've got an incredible augmentation to the surgeon's overall surgical coordination. And so we're pretty passionate about really how does that change the entire landscape for patients, for providers, both safety and quality and efficiency. I mean, there's some pretty amazing stuff. So it's how fast is that technology maturing, and then what pieces are maturing faster than others. So, for example, we're discussing and working on RTLS, so the ability to track patients in the room, clinicians and surgeons in the room. And you say, well, why is that important? Well, I need to know who's in there and who's not and who's ready to go. And I need to know when they're in a sterile field and when they're not. and to improve our efficiency, just how our time is used. Then you start adding computer listening, and what if the surgeon could narrate their operative note interoperatively, and then they were just editing it and not writing it or dictating it or transcribing it into that tool. So there's lots of pieces of technology that are emerging here. It's tempo though, right? I mean, how much can you introduce at one time, and how much of that technology is still maturing, and how much of it's really well done? Because when you put it in the OR, it needs to work. Not sort of work, not kind of work. It needs to work. And that's a three pieces of technology we're watching really closely.
And I think I saw Dr. Lewis nodding. He's like, yeah, I want all that, right?
Yeah.
And I want, give me
Yeah.
all that. That sounds
Yeah.
good.
Yeah, perfect.
Very cool. All right, gentlemen, I think we have covered it, but I want to give each of you sort of a opportunity for a final thought. And let me position it this way, as we go around the horn. Your best piece of advice to someone in your position at a comparably sized health system. So your position somewhere else, what's your best piece of advice to that individual under the guise of what we've been talking about today, either specifically robotic surgery or just the idea of um, working well with IT, and in order to practice medicine the way you want to practice it. Let's start with you, Dr. Copper.
So I'd say, this goes with IT as well as with any C-suite type people. Surgeons and clinicians need to understand the language of the people they're talking to, and how to translate your clinical wants, needs to their language so that they can understand why it's important. And that takes talking, that takes relationships, that takes some time on your part. You can't assume that they understand why it's important. So I think that's what I would say for clinicians, any kind, but definitely robotic surgeons. You better be able to articulate why is robotics important to you? Why is robotics important to your patient? And most importantly, how does it affect patient outcomes? Because patient outcomes are what all of us are driving toward.
Excellent. Dr. Lewis?
Yeah, I would echo all of those same sentiments. I think that patient experience is so important for us, and having alignment along our mission from the IT department as well as into surgery is critical to improving that patient experience. So, agree with Dr. Copper 100% that, learning how to speak that language and taking the time to articulate what you want to do for that individual patient is so important for IT to be able to understand that and to be able to support you in that goal. So agree.
Chris, I just got to mention that I'm hearing something very interesting. For the last 20 years, all we had heard was how IT needs to speak the language of clinicians. And now we're hearing clinicians saying we need to speak the language of IT. It's become that important for the users. The users understand now technology is part of our work. We need a good relationship with IT. We got to speak their language too. So both sides now want to come together. It's not just one way. That's interesting to me. What are your thoughts?
Yeah, we are a digital company, from scheduling through the OR, through billing. Every aspect of this organization is touched by digital opportunity, and at the center of that is the patient. And so there's a lot of focus in that space. While I appreciate that everybody needs to lean a little bit into that digital language, I don't think it's nearly as technically complex as it used to be. But my advice would be, go to the clinical areas and seek to understand. Go shadow. Go spend some time. And if you don't, and your phone rings, then your first question should be, where are you?
Mm-hmm.
And because that's your clue that you need to go see. Because what I will tell you is often what comes out over the phone and what you see and express and connect with people, completely different. And that when you go to those areas, you're demonstrating that you respect and value the work that's being done there more than you do sitting in your office. And that's you know, that's table stakes in this industry.
That is an excellent conversation, gentlemen. I think this is going to be super valuable, very interesting. I want to thank all three of you for your time. Really appreciate it.
Thanks for having us.
Thank you very much, Anthony.
Thanks, as always.